Today, my first talk is surgical margin status in hilar cholangiocarcinoma. And everybody knows the primary goal of rejection is R0, means a tumor-free surgical margin. It's like a central dogma in rejection of surgery. But the oncologic utility of this guide depends on clinical situations. We don't need to follow R0 concept in some specific situation. I talk in the ironical point in this central dogma cell. So clinical question of surgical margin status is a subclassification of status and clinical settings that allow um, R1 rejection. I focused on these two topics. So this is a textbook on the AJCC or USCC. This is a common classification system of our residual human status here. Finally, you perform the histological diagnosis at the surgical margin and will judge negative or positive. But in surgery, we perform the gross diagnosis of negative positive. This means a negative, the surgeon thinks this is a negative tumor, but histologically positive. But this is surgeon think residual tumors here. And also it's confirmed by histological diagnosis positive. So residual tumor is classified traditionally R012 and will be confirmed the impact of this status. R1, R0, R1, R2, with increasing number of the R status, the survival probability drastically decreased. Please note R2 rejection is a very poor. The survival is almost similar to unrejected patient. So we need to avoid R2 rejection. And we focus on this gross survival of R1 rejection and the type. We focus on the R1 type. This is an example of the duct margin involvement. This is no residual tumor with an intact biliary epithelium here. And this is cancer inside, carcinoma inside, and this figure has a CIS remnant here, and the main point is here, peridural invasion here. So this duct is judged on R1, but with remnant invasive cancer component. And this is R1, but with remnant carcinoma in situ. In situ cancer cannot penetrate the basal membrane here, so less invasive tumor behavior has that. But this is an invasive basal membrane and penetrate into the perineural space. So this has a aggressive character. So the question is, both have the same behavior or not? So a surgeon, this is Professor Wakai at Niigata University, one of my friends, because I worked in Niigata University for academic pathology work. So he proposed the CIS is not so good, not so bad. This is R1 CIS, positive margin with CIS. Both is same figure. And this figure means invasive survival of invasive cancer. This is all negative. So he said in situ positive is better than invasive cancer, but this is similar to R0 negative patient. So he reported a surprising finding over 15 years ago. The following studies, mainly from Japan, shows the same observation practice. The blue color indicates a CIS remnant survival path. survival do not significantly different between R1 CIS and R0. But we should realize that survival do not significantly difference between R1 CIS and R0 do not indicate not significantly not uh, indicate the equal. Please take a look this three survival curve. Interestingly, the patient, almost all the patient R1 series patient died of disease, especially the 3 to 5 years, the survival is reduced like this and die. So previous studies reported that part of not all, but a part of R1 COS patient eventually died of local disease relapse. This finding suggests R1 COS has a potential ability to grow um, to progressive tumor mass as a positive drug management. This patient, right side show the slow growing but have a invasive tumor mass like this, but he rejected our proposal of salvage pancreatic field maintenance, so he died of local relapse 3.5 years after initial hepatobiliary resection. The finding failed to clearly show this unfavorable biologic behavior in the data. So I think there are some problems in the previous studies about R1-CIS. First, there's a single center retrospective study and with a small sample number of R1-CIS because the many studies have 10 or included 10 or so patients. Yeah, 10. And second is the analysis is all rejection patients, including all rejected patients. Now we have 52 patients with R1 CAS in our university hospital. 52, so this is a very greater than previous studies, but we failed to demonstrate the statistically difference between R0 and R1 CAS. So probably we hypothesize that a strong prognostic factor would mask the mild effect of R1 CAS. R1 CAS has a prognostic factor, but its impact is very mild. So we selected some patients, so early stage patient, PTIS22 and N0M0, stage 0 to 2 disease, hospital. We selected these 172 patients here, 172 patients. And finally, this cohort divided into three groups, R0, R1 CIS, and R1 invasive. R1 CIS has only 18 patients. 7 patients converted to secondary R0 before the frozen section and was during the operation revealed the positive margin of CIS and we performed the additional resection. So an NE R0 resection successful case. And survival is shown here. R1 CIS worsened survival like this, especially after 3 years. The difference is not about 40%. And if we additional reject the R1 CIS and convert to the R0, so this is secondary R0 here, the survival is similar to R0. So this is a successful strategy in during operation. And this is also the local tumor relapse rate. After 3 years, local tumor, we found a local tumor mass like this. All these findings indicate potential and mild ability of progression to invasive tumor. And this is summary of our state test. Our two cannot be allowed due to comparable survival to unresectable disease. And R1 should be divided into R1 invasive and R1 CIS because of the different biological behavior. And R1 CIS is a strong prognostic factor, but R1 CIS is a mild prognostic factor. It works when other strong factor works. So this is I show the above, and now this is the Japanese guideline of the biliary tract cancer divided R1 clearly into the two categories, R1 CIS and R1 invasion. Then change, we show the another people. This is R0, R1 CIS, R1 invasion values. The 10% of this group accounted only for 10% of the rejected patient. And this is a 90% of the rejected patient. This is a small part of the patient. And we arrange here in detail our status and according to other very strong prognostic factor, metastasis and northern status here. N0R0, N0R1 series here, and this is a complex feature with 4 figures. And this is N1, but also the limit in the R2 rejection. Thus, R2 is the worst survival group in the rejected patient. M1 is the second. This includes the whole M0R1 English, M1R1 English practice. So this figure indicates in the case of nodal metastasis, our states are given what that indicate prognostic factor, of course, including R1 invasion R1 series. So we arrange this figure into very shortly into 4 figures into one, in one to R1. So R1 series is this is a summary of the prognostic factor of R. And the important point that M1 survival impact of M1 nodal metastasis and positive merging with invasive cancer is similar or identical. So no additional impact of R1 invasion in patient in M1. And the utility of R0 is only 40% of the whole. This group is beneficial. So attempt to R0 is justified only in patients without stronger prognostic evidence. So I show one case now. This is not hilar cholangiocarcinoma. Distal cholangiocarcinoma with a nodal status, nodal morphology. And this is PPD cassette in here. And we perform the cholangoscopic examination. Then, for example, here, this is here, we see a small fine granular mucosal pattern. So we perform the extensive sampling of this patient. So the tumor has an extensive upstream inside to infiltrate spread like this. But the negative biopsy is being is here. So I got one question: how do you manage this patient surgery? So this is a very difficult problem because usually with this schema we perform the pancreatic duodenectomy, but this is a confirmed positive margin. We from right trisectionectomy, cardiovectomy, and pancreatic duodenectomy in this patient. The resection line of the file that is here. The just just around the 2 and 3 time. But unfortunately, the patient has a positive CIS margin. Now, this is a invasive cancer component, and knowing invasive cancer CIS spread widely, than we anticipated. And the rejection margin ending the positive with cancer CAS. This is the tumor, histology of the tumor here, and caution should be paid. This tumor infiltrate here like a very poorly infiltration. This poorly differentiation is a very strong prognostic factor. This is the well differentiated adenocarcinoma from here. And this is a cause of this patient. She had liver metastasis for only 6 months years after surgery. And we performed a partial hepatectomy because this is simple single liver metastasis. But she has a multiple liver metastasis and died of disease that the result of recurrence of a period anastomosis. This case suggests a following point. Superficial spreading cholangiocarcinoma. She has a special type. And accurate diagnosis of lateral tumor extension, especially CIS, was very difficult, even by extensive biopsy and cholangoscopy. And robust prognostic factor. She has a N1 and T3 pancreatic invasion and poorly differentiated component, triggered early disease relapse and death. And the R1 CIS little affected the survival in the face of strong engagement. And finally, the initial HPV I performed was a big choice. This is a question. So again, we show the same scheme like this, but we caution that disease relapse is the occurred group of M0 and R0 patients. So subset analysis R0 and 0 group should be conducted and just for the further assessment. I showed two figures about the rejected patient. This also both is rejected by the rejection or middle ground. This is a little bit upper ground function. Please see the rejection margin, proximal and distal, and tumor, macroscopic tumor here. Tumor has a nodular infiltrating tumor, but the wall thickness reached here. So in this, the left case, the rejection margin keeps a 5 millimeter or more safety margin. In the upper side is also, but here, very near margin. This is also the R0. Those patients are 0, but this is very, very near, less than 1 millimeter. Proximal directions are taken over. Do you accept a very short safety margin? Probably no. The concept of safe distance in the lab is proposed by Professor Endo, the president of Japanese HPP Society, over also the 2000. He classified the rejected specimen into 3 subtypes. Because we sometimes perform the frozen section diagnosis and get negative result. But the rejected specimen, this is positive. This is negative. This is a narrow margin. And when we perform the frozen section, we get positive like this. And additional rejection, and both the additional rejection will perform in this case, and negative and positive. So the situation using the frozen section analysis classified into 3 categories. R0 with wide margin, R0 with narrow margin, here and here, D, and R1 in basic cancer. So the point is here. This is group A. R1's wide margin is better than R0 with narrow margin. And R0 but narrow margin comparable shows a comparable survival with patient is R1 invasive management. So we check for this conference, I checked the data of Nagoya University Hospital. And this is a wide and narrow safety management range in general zero patient. Of course, a longer safety margin has a better survival and a shorter survival, shorter margin with short survival up to about 15% difference at 5 years. So the subtype of margin improvement additionally divided in here R0 and narrow and R0 wide. But actually, the surgical margin status assessment is very complex because we have to check the multiple site of the rejected specimen. So it's a challenging and complex. And we check the curative intent hepatectomy patient between this period. So we found unexpected R1 invasive is found in 80% even after curatively intended hepatectomy. Then the positive margin site is similar in radial margin and positive margin. But in details, we found a hotspot of the positive margin site. One is a proximal duct stent and another is a liver transaction plan. We have to revise our surgical strategy according to this finding. R1 invasive overall incidence is 80% as shown before, and according to the hepatectomy type, this is left hepatectomy and this is right hepatectomy has over 20% of R1 rate. But the left trisectionectomy and the right hepatectomy is shown below the 20%. Divided into a detailed site like this, we see characteristic feature here. The right trisectionectomy has a high incidence of proximal duct margin. And as for liver transaction frame, like this figure, the left hepatectomy has a high incidence of liver transaction frame. So because one of these regions, we perform the right trisection nectomy in very advanced case like this. So this case, this patient receives the right trisectionectomy, but the rejection margin is very near. So our strategy for right trisectionectomy lead to the high incidence of this 20% effective margin on proximal biopsy. And liver transaction frame after the hepatectomy is shown here because of the conventional liver transaction frame preserving the middle hepatic frame like this. So EU the sulcosoma middle hepatic frame like this. But this is the point is very near like this. So the point the left hepatectomy has a higher incidence of liver transaction frame like this. Radial or liver margin also matters. It shows that R0 rejection versus R0 rejection. This is radial margin positive and distal margin positive are completely similar. This is liver transaction frame negative and liver transaction frame positive. So we have to kill the duct margin and also the radial the liver transaction frame is left hepatectomy is shown here. So all is a conventional rectal hepatectomy. So preserving the middle hepatic frame. We can see the surface of the middle hepatic frame. And it shows a very near to the tumor, left-sided cholangiocarcinoma. This is negative, but very important. This is also the positive. The surgeon performed this surgery with recognition of the positive margin during surgery. So this now I show the summary of this lectures. I show the sub-classification of R0 status. Conventionally, R0 to R2, but R0 is divided deeper than R1 is divided into two subsets. Second is a limited benefit of R0. This slide shows just one. Utility of R0 is only 40% of the flow. I can believe R0 justified only in patient without strong prognostic factors. So during surgery, we have to check the normal status as a vascular invasion or something like that. That has a very strong impact or strong impact on survival. And third is the hot spot of organ management. So if a transaction trend in the left conventional vertebrectomy, in the right trisection method. So we should choose the type of vertebrectomy on the basis of these margin factors in the radio assessment. Thank you for your kind attention. I'm very happy to talk about the margin status of the concept of Nagoya University Hospital. This concept is not so comparable to the global standard. Thank you for your kind attention.